I'm going to present a piece of work that we've been doing for the past few months, looking at inequalities in 277 conditions in primary care. This is from a small group of early career researchers from the University of Birmingham, looking at how we can automate more of the analysis that we're doing. So we now have infrastructure and pipelines for data that takes GP recorded data, primary care data from Vision 3 systems, which CPRD then prepare and manage to create research-ready data. We at the university have a platform that extracts the data into study designs ready for analysis. And now we're building automated analytics on top of that. And so as part of that, we've done analysis of 277 conditions in primary care, which are responsible for the highest burdens of disease and that are chronic conditions that are likely to be recorded in primary care. And the problem with this is that when we start to look at the inequalities in that, we find that we have 277 conditions by the 5 ONS ethnicity groups and deprivation deciles or quintiles and regions. And so there are 10 to 15 categories that we then want to analyze these conditions by, and there's far too much data to actually make sense of. So this is a set of methods looking at how we can systematically identify health inequalities in primary care diagnoses, and particularly to identify those diagnoses and conditions which appear to be higher prevalence and increased in their prevalence within particular subgroups, so that we can identify conditions that might be contributing towards health inequalities. And so I'll present an example here looking at incidence in ethnic inequalities, but this is hopefully a fairly flexible set of methods that will apply and generalize across different dimensions and look at prevalence as well. And in particular, we're only going to look at the year of 2021, and we've extracted for this study all patients aged 0 to 115. The only eligibility criterion was sufficient data quality as judged through the CPRD processes. And we're looking at those 277 phenotypes in this study. What we've done, we firstly calculated prevalence or incidence as the number of cases per person years. We then age-sex standardized it using the UK mid-year census population estimates, and then calculated risk ratios for the different subgroups compared to the overall population. And we use those risk ratios to create expected and observed incidence and prevalence rates, which we then use to judge whether there is a signal there that might suggest an increased inequality in that particular condition. So in these results, in the sort of incidence, we've got what might be expected as the most common conditions, the highest incidence being hypertension, cataracts, osteoarthritis, anxiety, atrial fibrillation, the most common conditions, and up to 0.8% of the population being diagnosed each year with hypertension, which is unsurprising because there's so much case finding effort that goes into looking for those conditions. But that's obviously the crude overall population rate. And when we start thinking about what might be going on in individual subgroups, and calculating those risk ratios, what's different in the subgroup, here we see that the distribution of prevalence within the subgroup compared to the overall population is very skewed within different ethnicities. And we can see that for the Black population, there's a very large number of conditions that are far more rarely diagnosed. This sort of left tail of this distribution is conditions that might be diagnosed half as often or even less in Black people compared to the overall population. Unsurprisingly, the white population is driving that overall population, that comparator, and so the distribution, the risk ratio is very close to 1. And then with the Asian population, again, skewed towards many conditions being less commonly diagnosed, with fewer being much more commonly diagnosed, but it seems to be less extremely positively skewed than with the Black population. However, the means for these risk ratios, the number of actual diagnoses made, is very close to 1 across all of these different groups. And so that suggests that there are differences within specific diagnoses, but overall it's roughly the same across all groups. And then if we want to see what those individual groups, what those individual diagnoses might be, we can plot both the actual incidence rate on the y-axis as well as the incidence ratio on the x-axis, and look at what conditions might be increased both in the incidence ratio on the x and that are high incidence on the y, suggesting important health problems that are increased in incidence. And again, if we look at Black population, we find that there are increased end-stage renal disease, increased leiomyomas, which are uterine fibroids, etc., compared to if we look at the Asian populations, we've got increased incidence of diabetes and diabetic eye disease, which in some ways they're what we expect to see here, but also these signals help us to see what are those important conditions when we take everything together. And again, we can use this is using a chi-squared confidence interval to look at where those big signals are as a funnel plot, and those conditions that lie outside of the funnel plot, outside of 2 and 3 standard deviations as calculated using a chi-squared exact test for the expected rate of diagnoses. We can see that there are many conditions overdiagnosed. There are also conditions underdiagnosed, and so this can be used in the same way to look at things that might be underdiagnosed. For example, we often see mental health conditions tend to appear underdiagnosed when we look at ethnic groups. So as I mentioned, we've got increased incidence and higher risk of end-stage renal disease in Black populations, increased renal malignancies, leiomyomas, and so we're working towards publishing all of these results with both the age sex standardized incidence and prevalence rates, and then highlighting those conditions that appear to be contributing towards health inequalities. Thank you very much.